Good evening to all the aspirant. Good evening, sir.
Yeah,
Sir, shall we start?
good evening. Yeah, we shall start.
Okay. So today's topic is acute coronary care, which is class 2. And the speaker that we have here is Dr. Sangshaptak Saha. He is an associate consultant in critical care medicine at Apollo Hospital, Kolkata. Thank you, sir.
Good evening, everybody. So today is the second class for the acute coronary care. Basically, I have done related to the acute coronary syndrome. We have discussed everything that was there to discuss in the last class, including the posterior wall and inferior wall AMIs and the ECGs. And there are also a small test at the end of the session, and I also shared the PDF of that, the PPT of that. So today, basically, we shall discuss about the pericarditis and the myocarditis. Not the whole of those things, but only the acute parts and those which are relevant to the ICU. We shall also be discussing a bit about the pericardial effusion, constitutive pericarditis, and in the end, we have a very special topic, brief 15 to 20 minutes talk. We shall get there as as we reach there. Yeah, the last 15 20 minutes, at least for me, it was very interesting to prepare for that. So, okay, I think everybody should keep their mics. Yeah, mute. That will be better. So starting off with this myocarditis, this is basically the definition. So histologically, we have the Dallas criteria and the immunological and immunohistochemical criteria. So basically, because this is a part one, EDIC part one exam related class. So basically, they will ask about the Dallas criteria directly, or they will ask what is the basis of the classification of myocarditis, especially in the ICU. Then they will tell the immunological immunohistochemical criteria. So most of the things, the most of the slides they have prepared, those are direct questions from previous EDIC questions. And it's I want to repeat that it is not a class only on myocarditis and pericarditis, because that is a large thing and that is not required for your EDIC part one. So epidemiology, the global incidence is something like 4 to 14, 15 people per lakh patients annually, with a mortality rate of 1 to 7%. But why we have included is because this is very favorite of them in the recent years. This myocarditis in SARS-CoV-2 infection versus COVID-19 vaccination. So myocarditis risk increases by a factor of 2 and 15 after vaccination and infection. Higher rates were with Moderna vaccines followed by the Pfizer vaccines. And strangely, males were more susceptible to myocarditis. Okay. So there is something called myocarditis, which is occurring after the COVID-19 vaccination and also after COVID-19 infection. So COVID-19 infection myocarditis survival rate is worse, whereas if it is following the vaccination, survival rate is more. So once again, the vaccine is causing the myocarditis, but the people are surviving more, and the mechanism is different. The mechanism is mostly this hypersensitivity reaction if it is post vaccination, and if it is this post myocarditis, if it is post infection, then it is mostly the endothelial injury and microthrombus. Both of these, this endothelial injury, microthrombus, and hypersensitivity reaction, both of these are previous MCQs. Hypersensitivity reaction is with the vaccine, it has a better survival rate. Okay, this is what you have to remember. So again, the classification, why do we need it for the exam? This is because the eosinophilic myocarditis, giant cell myocarditis, cardiac sarcoidosis, these are the three for which you need the corticosteroids. We use use corticosteroids in every case of myocarditis. Like the guidelines, these are the three where you have to use the corticosteroids. Obviously, the higher dose of corticosteroids, 2 milligram per kg body weight of IV methylprednisolone, followed by tapering off gradually over 10 to 14 days. And you can also use mycophenolate mofetil and other immunosuppressants as well. Whereas in the lymphatic myocarditis, this corticosteroid can be used, but it is optional to use. So it is not a grade 1 recommendation yet. Whereas in polymorphic myocarditis is basically post-infection and their corticosteroids should not be used. So no role of steroids here. Basically, they will ask about this eosinophilic. Giant cell is a very favorite of EDIC 1 and also cardiac sarcoidosis where you have to use the corticosteroids. Okay. So basically, they can give you a clinical case scenario where the patient has got some viral infections, usually HIV, hepatitis, mumps, influenza, or a bacterial infection like pneumococcus or psittacosis. It can be following candida or aspergillosis or following leptospirosis. In fact, we have a patient right now in our ICU who presented following a travel to a hilly area with AKI, acute liver injury, transaminitis, and thrombocytopenia. We sent a leptospirosis panel, but it came out to be negative. Then we again repeated it, and we are awaiting the result. But the patient has got all the features of leptospirosis along with the travel history. So we are suspecting that the patient may have got the leptospirosis, and the patient also has got reduced ejection fraction. He's a young patient. He's what I mean. He's in his 40s, 45, 46 years old. No prior history of cardiac disease, but his ejection fraction was around 40%. Unlikely that he was having ejection fraction of 40% before the disease. So it may be a case of leptospirosis induced myocarditis. Just a practical case scenario. So it is not something impractical. Okay, this myocarditis, inflammatory myocarditis, all of us see the ICU, and not only the septic shock related myocarditis because the pathophysiology of that is different. And of course, the Chagas disease is there, which is a common chronic, but Chaga, yeah, in European centers, Chagas can happen. It can be a question, at least it does not happening in native South American disease. And of course, the Southeast Asian countries, malaria mediated myocarditis is very common. So it's a wide range, but we have to remember that mostly it is viral. It can be bacterial, streptoneumo. It can be Spirochetes leptospira or malaria. Candida and aspergillosis will not come as myocarditis in an EDIC Part 1 exam. And these are all the non-infectious causes. We just have to remember these vaccinations, snake bites, these infections, and sarcoidosis, thyrotoxicosis, collagen vascular disease, and maybe heavy metals, and of course alcohol toxicity, which is a separate question altogether. So how to because in EDIC 1 they can give you direct questions, but in many times they give you the clinical picture. So patient presents with the flu-like symptoms with some chest pain, and these are the ECG findings, and then you have to diagnose. So clinical features, physical examination, mostly the features of LV or RV dysfunction, depending on what is there. It can be tachycardia, it can be the gallops, it can be pericarditis, peripheral edema, ascites, pleural effusion, pericardial effusion, elevated JVP, hepatomegaly, and of course shock. Any of them can be the findings. So these are basically findings of left ventricular, right ventricular failure, depending upon which part of the heart is involved. So clinical presentation can be as a case of acute heart failure, dilated cardiomyopathy, or it can be a subclinical case. Now, this acute heart failure, we have to manage as a heart failure only. So we have to manage the preload. If it is a patient is in overload, we have to use diuretics or a renal replacement therapy with ultrafiltration removal. If the patient is underfilled, we have to give some fluid volume. We have to manage the afterload. We have to use the dobutamine or milidone to decrease the peripheral vascular resistance if it is increased. If not, we have to use the inotropes like vasopressin and noradrenaline. Noradrenaline is the drug of choice. So the usual acute heart failure management. And of course, there is also the option of using the ECMO and the LVADs. Remember, they last year or the year before that, I think they gave a question on EDIC 1. I'm talking about. They gave a question on myocarditis, and then it was a long stem. So patient presented like these disease features, there's ECG changes, he was in shock, all the infective cultures were ruled out, and the patient's ejection fraction was something 20-25%. He is not responding to anode drops, his BP is still low, 80/50, despite a non-adherent vasopressin, and triadobutamine also been given, his peripheral vascular resistance is still low. So what will you do next? Obviously, the answer was VA ECMO. So in an MCQ exam, it seems because you have the options in front of you, it's not that difficult. But you just remember that yes, VA ECMO is a part because it is nothing but an acute heart failure. That is why we are including this in the acute coronary care class, because although you do not include this acute coronary care in general, but I included this because you have two classes and there's nothing to discuss on acute coronary care and it is useless to discuss the same thing again and again. So we are discussing this right now. So you remember that acute heart failure may be with dilated cardiomyopathy, which underlying cause will be myocarditis, or there may be subclinical myocarditis. There can be transient increase in troponin or ECG abnormalities after an acute viral illness or vaccination. This vaccination I am repeating again and again. This is a very important MCQ topic for anyone. Okay. Differentials can be anything. It can be an IHD, ischemic heart disease, it can be a heart failure, it can be pulmonary edema, it can be dilated cardiomyopathy, it can be alcoholic cardiomyopathy, it can be sepsis. As I told that they will tell you that the septic markers are not there. So it can be anything. So differential they will not ask in EDIC one, obviously. But you have to differentiate it on the basis of the clinical scenario given. Because although they will not ask directly, but they will give something. What is your next step? Whether you will do an echocardiogram or whether you will send a sepsis profile. So that you have to pick it up from the step that is being given. Very important. So blood markers, as you have discussed, we obviously in a cardiac case we shall do the these basic cardiac biomarkers, that is the troponins and the NT-proBNP and the CPKMB, those things. But because this sepsis is a cause, I mean it's a DD, so we should also be doing this ESR, CRP, and the procal. The procal obviously will be negative in this case, but the ESR and CRP will be increased because it is inflammatory, right? And that is why CRP is not that good a marker in case of sepsis, but it is a good negative marker. But here CRP can be elevated up to 99% of cases. And of course, you have to work up for this hepatitis panel and the HIV and the leptospira and the malaria cultures, etc., etc. And in advanced centers, and of course, the patient has got financially able, then the serum cardiac antibodies and endomyocardial biopsy, and of course the MRI, cardiac MRI. This you need to do. We shall discuss on more on cardiac MRI and EMB in the next few slides. Okay. So another favorite topic for this EDIC part one. What are the ECG changes of this pericarditis or myocarditis? Pericarditis, there are typical ECG changes. In myocarditis, they are mostly non-specific STTF changes. It can present with simple atrial tachycardia or fibrillation, or it can present with a high-grade AV block. Okay. So you cannot really differentiate on the basis of ECG findings. The ECG will just tell you that something is going on with the heart. While in the echocardiography, ESC recommending standard TT. So they will ask whether TOE needs to be done or not as a baseline investigation. It is not a baseline investigation. You can do a TOE in the latter part. It is an advanced investigation. A TTE is enough. Just a minute. Sorry. So yes. So indications for endomyocardial biopsy for the EDIC part one, you don't have to remember all the cases, but if there is suspicion for this giant cell myocarditis, as I told previously, giant cell myocarditis is a very favorite topic for EDIC part one. If there is hemodynamically significant arrhythmias, if there is advanced heart failure, if there is a suspicion or diagnosis of systemic autoimmune diseases like SLE, polyarteritis nodosa, rheumatoid arthritis, mixed connective tissue disease, then you have to do. If there are acute symptoms of heart failure, refractory management, then you have to do. So, okay. So mostly giant cell myocarditis before using the steroids, acute heart failure, this refractory arrhythmias, And if there is systemic rheumatological disease, then you have to do the endomyocardial biopsy. It's easier to remember. Dallas criteria, only the name is important basically, rather than the whole criteria. Basically, they do biopsy, and depending on the biopsy findings, they classify. Okay, based upon the inflammatory infiltration, fibrosis. This much is enough. Don't have to remember the whole criteria. The name is good enough. So this is a nutshell of what we have discussed so far. So what is the clinical presentation? It can be an acute chest pain or a new onset or worsening dyspnea, trace or exercise. It can be palpitation or unexpected cardiogenic shock. What is the what is the diagnostic criteria? Diagnostic criteria basically Dallas criteria, but that is the biopsy based. Other than that, ECG or a Holter we can do. We can do a echocardiography, obviously. We can do this elevated. We can do these cardiac markers, TROP9, and we can do a this cardiac MRI, or you can do an echo or angio also. So clinically suspected myocarditis, we basically need a clinical presentation with the clinical features. We need the diagnostic criteria for different categories symptomatic patients. And importantly, the angiographically, there should be the detectable coronary artery disease should be absent. So an angio is required for diagnosis. Okay. Coronary artery stenosis should be, it should be less than 50%, obviously. Management is basically hemodynamically unstable patient. Management is just like a heart failure management in ICU patients. We have discussed that already. For hemodynamically stable patients, all again heart failure management with the diuretics, beta blockers, ACE inhibitors, and the spironolactone, and fluid management of fluid overload if there is any. Okay. So management is not that important because it will basically the heart failure management. It is just understanding that this is a case of myocarditis in exam. That is what is important, and remembering the Dallas criteria. So, is there any role of immunomodulatory therapy? Yes, high dose IV immunoglobulin, immunoadsorption. These are not proven. These are not proven, and these are not grade one recommendations either. But yes, you can use it. But they will mostly ask whether it is a grade one recommendation. Your answer will be no. This is again a management algorithm. Just to highlight the same thing again, you have to remember the symptoms, which are basically any symptoms related to cardiac cause, an ECG, an echocardiogram, and a troponin levels. If it is uncomplicated presentation, then we can admit, we can repeat an ECG, troponin levels, and perform a coronary angiography. As I told, it is required for ruling out any coronary artery disease. And if it is a complicated presentation, we basically have to do it like a acute heart failure and its complications like management. So to manage the arrhythmias and the fulminant myocarditis like features. If there is a persistent chest pain, then we can give some insights. The next question is when to use the steroids. As I told in the first slide, that is the most important question. Giant cell myocarditis, eosinophilic myocarditis, cardiac sarcoidosis, you have to use immunosuppression. Lymphocytic myocarditis is a case by case basis. Okay. And cardiac MRI can be considered in patients without mechanical cardio support if the EMB is not available locally or facility or low experience. So this is an obvious indication of cardiac MRI. If your diagnosis is suspicious or if the EMB is not available, then you can go for a cardiac MRI. So cardiac MRI is not recommended in every case. This again is a previous year's question. See these simple things they ask in EDIC 1. You need to ask the patient that he needs to avoid intense exercise for 3 to 6 months even after discharge. And the follow-up is 6 months echocardiogram or CMR. Both of them are previous EDIC 1 questions. Okay. I'm marking those things which you see, so you can take the screenshots if you feel like. It's not an issue. Okay, so we shall discuss fulminant myocarditis and then we shall come to the conclusion of the part one, which is myocarditis. Next is pericarditis, and the last 15 minutes, as I told, will be something very, very interesting. So what is fulminant myocarditis? Why it is important? It is important because it can kill the patient. That is the simplest answer why it is important. So the patient will present with circulatory compromise, maybe a right-sided heart failure, although left-sided heart failure can also occur. In a de novo acute heart failure, young patient, we have seen 3 to 4 patients in our ICU. All the patients were under 40 or 45 years of age with fulminant myocarditis, and I think 2 of them died. One of them she had to undergo tracheostomy, and the other patient, recovered in 7 to 8 days. And the tracheostomy patient also required a VA ECMO. So yeah, so very bad, prognosis of the disease. The VA ECMO patient actually survived. She was a young 23 years old female. She went to her college, and next day she had a fever, and after 2 days she was in shock. When she came, her BP was not recordable. She underwent a CPR cycle. She achieved ROSC. She went into a VA ECMO by our ECMO team. Within, I think, 30 minutes of her presentation, she was already being cannulation was, it had only started, and within 1 hour she was on a VA ECMO support. Basically, that's why she survived. Otherwise, though, she would have died. That's the bottom line of ECMO, right? ECMO saves people. There's no doubt about that. If you're working in an ECMO center, you will know. Otherwise, there's a lot of people who do not work in ECMO center in intensivists only, who are like, it's so costly and many less people survive. But yeah, if you're 23 years old female survives, who went into the disease the next day after going to normal college, then yeah, I believe it's worth it. Anyway, so the investigations will be the same investigations, no extra points. You just have to remember that if the patient is presenting with acute shock and young patient, maybe chest pain and those things after flu-like illness, suspect fulminant myocarditis. Because in the exam they'll not give you the fulminant myocarditis, they'll give you very closely related answers. Fulminant myocarditis, ACS, pericarditis, pericardial effusion, maybe something like those things. You have to rule those out. It will be very close. It will not be likely fulminant myocarditis and acute liver failure. Because obviously then the acute liver failure will not be the answer if they had not given something like jaundice or something. EDIC one, the options will be very close to one another. You have to rule it out clinically. Just read the question one time or two time, they will definitely hide some clue there.